All right. Well, welcome everybody to our PISCE seminar for November. My name is Megan Lane Fall. I'm the Executive Director of the Penn Implementation Science Center, and it's my pleasure to introduce Dr. Kate Rendell, who's our Director of Cancer Implementation Research, and she has a blossomed implementation science portfolio, but she's going to introduce our visiting speaker. So I'll throw it over to you, Kate.
Thank you, Megan. And we do have 3 Megans on the call out of 7 people, which is a very high proportion, which is amazing. And so I guess Megan does not clarify which Megan, but I have the honor to introduce Dr. Clarke Roberts, who I had the lovely opportunity to get to know as a postdoc at the NCI. And she really is a leader, was then and has continued to be in the intersection between precision medicine and implementation science. She is currently an assistant professor in the Division of Pharmaceutical Outcomes and Policy and the Director of Implementation Science in Precision Health and Society at UNC's School of Pharmacy. Her research focuses on evaluating and improving the implementation of genomic medicine. And to date, her research has largely focused on the intersections between genomic medicine, health equity, implementation science, including research about the implementation about population genetic counseling, cascade screening for hereditary conditions, and many other precision-based approaches, both locally, globally, and nationally. So with my pleasure, I will turn it over to you, Dr. Roberts.
Thanks, Kate. And is everybody seeing my slides versus my presenter mode? Okay, great. So today I'm going to talk a little bit about achieving promise of precision health or precision prevention through implementation science. And I'll talk a little bit about why I think implementation science is particularly important when it comes to precision health research. And then I'll talk a little bit about a body of work that I'm doing around population genetic screening. So just to start, I know this group knows a lot about implementation science, but maybe a little bit less about precision health, public health genomics, precision medicine, precision prevention, precision public health. It's called a lot of things, and I thought we could maybe talk a little bit about this terminology and exactly what it is that I'll be referring to. So when the Precision Medicine Initiative was announced in 2015, the definition that was used for precision medicine was treatment and prevention strategies that account for individual level factors, including lifestyle, environment, and genetics. And I think more recently, the terminology is sort of separated off between precision medicine, really referring to treatment focused efforts, precision prevention, focusing on prevention strategies, and what used to be called precision medicine, I think now is often referred to as precision health. Also, I think generally when we think about precision medicine or precision health, we think about it synonymously with genomic medicine or public health genomics. And a lot of what I'm going to be talking about today falls within the group of genomic medicine and public health genomics. But I will say that that's really just a component of precision medicine, and that really the full view of precision medicine includes individual level data, not just through genetics, but also through lifestyle and environment factors. Some of the other terminology that you'll hear, in addition to precision health, is precision public health. So if we think about precision medicine being getting the right treatment to the right patient at the right time, precision public health is thought to be how do we get the right interventions to the right populations at the right time, and really taking more of a population health view. The work that I'm going to describe later really falls into this sort of realm of precision public health and specifically public health genomics. But I think implementation science is particularly important in the field of precision health. And often I get asked whether or not the considerations for implementing a precision health intervention really differ at all from any other type of health intervention. And I do think that there are some unique challenges that come along with public health genomics or even clinical genomics. So first, there are a lot of unique ethical, legal, and social implications about incorporating genetic data into healthcare. These can include things like genetic discrimination, which we certainly have protections for, but that vary by state, and also have certain gaps on a federal level. There also are sort of ethical and social implications around how data is stored and protected. We can think of genetic data as being perhaps some of our most personal data that we have. And so there are some unique challenges that arise due to that. Also, we know that health literacy is relatively low in the US and around the world, but genetic literacy is slightly different, and it's perhaps even lower than general health literacy. When you think about it, many people have probably never taken a course in genetics. For most of us, maybe you learned about it in a chapter of a biology class in high school. And I don't know about you, but I remember very little of the details that I learned in high school. And so when we're thinking about engaging patients and the public in obtaining their genetic information in order to inform their health, there's got to be a lot of education that happens as well. And this is true not only among the public and patients, but also among providers and specifically non-genetics providers. There's quite a bit of data out there suggesting that knowledge and awareness is suboptimal among non-genetics providers. And this plays into this other challenge around genetic risk communication. And certainly there are healthcare professionals who have specialization in genetic risk communication, clinical geneticists, and even more commonly, when we think of risk communication, genetic risk communication, we think of genetic counselors who are trained to counsel patients about their genetic risk. But we know that we have a shortage of genetic counselors. There's also a lot of variation in genetic counseling state licensure, which means that there isn't state licensure for genetic counselors in certain states like North Carolina, which limits their ability to really engage with patients at the full capacity of their ability. And so when we think about genetic risk communications, there are a lot of challenges that arise. And the research shows that providers repeatedly have reported feeling like they have low self-efficacy for communicating genetic risk to their patients. There's also a lot of rapidly evolving knowledge around genetics. So genetic variants are constantly being reclassified as we better understand the association between genetic variants and health outcomes. And so thinking about how we continue to update this information and give it back to providers who can then share it with patients, and so that they can act on it in terms of health management, is really complex. And thinking about how we convey that information in an efficient and an effective way is really challenging. We also are understanding increasingly the association between variants and health outcomes more generally. And so as new tests and new information becomes available, how do we make sure that providers are able to stay on top of all of this rapidly changing information? There's also big data in a way that there probably has never been before. And we are capable of storing and analyzing big data better now than in the past. But when we think about how large our genome is and what that data storage looks like, and then we think about the goal of precision health, which is to incorporate not just genetics and a person's potentially genome, but also lifestyle and environmental factors, these data sets could be huge, could be incorporating mobile health data. And so thinking about not only how do we store and pay for the storage of these data, but also how do we analyze the data and do so in an efficient way is, I think, a remaining challenge. And then while the costs of genetic sequencing have decreased over time, the costs, there still are a lot of costs associated with, again, storing data, as well as the downstream care that a person may need to receive if they have a positive result, especially when we consider that it could be a rare condition that would need to be attended to. And there are a lot of other ways, I think, that public health genomics and clinical genomics differ from other implementation challenges, or perhaps are a little bit more unique, but I think that these are some of the main ones. And the main thing that I want to sort of demonstrate with this is that there are a lot of multi-level challenges here. And this, I think, demonstrates the fact that a lot of public health, precision public health interventions and precision health interventions are complex interventions, which we know are going to be more difficult to implement. In addition, when we look at this list, we can be thinking a lot about the fact that these unique challenges likely disproportionately impact underrepresented populations and underserved populations. Not only is there underrepresentation of populations in the genomic data that we have that underpin a lot of these technologies. Those databases are predominantly from people of European descent, but we also have a lot of issues around how do we really include and use these public health genomics and clinical genomics interventions in representative populations, understanding that there have been a lot of historical discrimination and biases within our medical system. How do we work to provide the trust that's necessary for all patients to feel comfortable sharing their personal genomic data and their personal health information at an individual level is something that we need to especially be thinking about. And because of this, and because of the fact that public health genomics and clinical genomics innovations are so complex, I think that implementation science is going to be really important for thinking about how we unroll them and how we use them in this growing era of precision health. And there have been a lot of calls for implementation science in genomic medicine, implementation science in precision public health research. And a lot of these calls have recognized that it's this overlap between implementation science and precision public health has been sort of underexplored. And while it's starting to grow a little bit, there's still a lot of need in this field. Recently, the literature was sort of explored again to see to what extent has implementation science in precision public health broadly grown over the years. And what they found was actually that there has been some increase in research in this area, but it really has stopped in the exploration and preparation phases of implementation science. So here's the PISCE framework, and often what we're finding is that there's been a good amount of research exploring the needs of the patients, public, and community around engaging in precision public health interventions. There's been a lot within the preparation phase of implementation around identifying implementation barriers and facilitators for precision public health interventions. But there's been a lot less done around using rigorous implementation science methods to actually implement and evaluate precision public health interventions. And there's hardly anything around sustainment. So thinking about research that ensures that evidence-based practices continue to be implemented in order to impact population health. The one potential exception would be there's starting to be some really great cost effectiveness research done to try to demonstrate the potential cost effectiveness of some of these interventions as they emerge. And so I think what this shows us is that there really is a lot of room to continue to grow research and implementation science and precision public health. And today, what I'd like to do for the majority of the time is talk a little bit about some research that I'm engaged in around implementation science and specifically public health genomics and some of the work that we're doing that's centered a little bit in the preparation and implementation phases. And so the example that I'm going to be talking about is around population genetics screening. And just in terms of a little bit of background, it's estimated that about 3% of the population carry rare genetic variants that cause hereditary conditions that are preventable and treatable if they're diagnosed before symptoms develop. Some examples of these conditions include Lynch syndrome and hereditary breast and ovarian cancer syndrome, as well as familial hypercholesterolemia, so associated with cancer and cardiovascular disease, among a few others. And when we put this number into sort of context, 3% of individuals in the United States comes out to about 10 million people. And when we think about other conditions that we study, colorectal cancer, for example, is prevalent in about 4% of the population. And so even though these are rare hereditary conditions, when we look across preventable and treatable conditions, it's actually a pretty impactful number of people who may carry these conditions and require specialized care. And what I mean by preventable and treatable is that if we identify individuals with these conditions, there are things that we can do to reduce their risk of having cancer or cardiovascular disease. And so here are just a few examples with hereditary breast and ovarian cancer syndrome and Lynch syndrome. There are a number of different types of cancer screenings that individuals can undergo, as well as risk-reducing surgeries. There also are medications that can be taken to lower risk of cancer. And these are all in clinical guidelines. In addition, familial hypercholesterolemia, which increases risk of cardiovascular disease. There are a number of medications that can be given to reduce risk of cardiovascular disease that are in the guidelines. And there's lots of evidence to suggest that these types of preventive services can reduce morbidity and mortality associated with those conditions. When we currently think about our genetic testing guidelines, though, they're reactive. And what I mean by that is we usually wait for an individual or a significant number of their family members to develop the disease before they are eligible for genetic testing to determine whether or not they have the condition. And so I think that while a reactive testing approach perhaps increases our likelihood of identifying people with the condition among those tested, it really represents a missed opportunity in disease prevention and control because we aren't reaching people prior to symptoms and potentially devastating diagnoses. And so there's been an increased thought around what if we move genomic medicine from this more reactive type of approach to a more proactive approach, where we identify individuals who are at risk in the population and manage that risk before any sort of disease develops. And so the idea here is, we could almost be thinking of this as a way of expanding newborn screening, where we are doing newborn screening, but in adults, where we are doing genomic screening of adults so that we can align management for those who are identified to be at risk for these, or to have these conditions and be at risk for poor health outcomes. And so increasingly, I think this idea is really taking hold, though, again, it's not guideline recommended yet. But there are bodies of experts who have started thinking about and making recommendations around what population genetic screening could look like. And the National Academies of Sciences, about 5 years ago now, put out a recommendation that the CDC Tier 1 genes, excuse me, so those genes that are associated with the 3 conditions that I mentioned, hereditary breast and ovarian cancer, Lynch syndrome, and familial hypercholesterolemia, that population genetic testing of genes associated with these conditions might be a good approach for population genetic screening. And again, the selection of these 3 conditions is because they are among the most common, they are highly preventable and treatable, and we know a lot about the genes that are associated with these conditions. And so these programs, despite the lack of clinical guidelines, are starting to grow. We can think about the Precision Medicine Initiative, now all of us, as an example of what that might look like on the federal level. There are a number of research studies that have developed population genomic screening, and it's even starting now to move into the clinical space with clinical offerings for population genomic screening. And so I looked, and even Penn has a preventive genomic screening program through their genetic services. And so these programs are growing, and we were really interested as we were learning about all of these new programs coming up a little bit more. We wanted to understand a little bit more about the contextual factors and the characteristics of these different programs. And so this work was led by Kim Foss at UNC, where we looked at 12 different population genetic screening programs across the US, and their catchment areas really do cover most of the country. And we were interested in just understanding, what are these programs looking like? What do they include? How are they being delivered? And what we found is that they are really, really different. The program settings vary quite a bit. Some are health system wide, others are clinical pilots, some are statewide initiatives, and others are just offerings through genetics clinics. The enrollment, or the way that patients are brought into these programs, really differs. Many are provider-led, some are patient-led, and some are a combination of the two. And most of the programs that we looked at, all but 2, really are focused on adults. However, 2 also included population genetic screening for kids, which I think is a really neat area, and something that I'm working on with some collaborators as well. Most of the programs provided the genetic testing to the patient at no cost, and that's something that I'll come back to. Cascade testing or family testing in individuals who have a positive result was available in 9 of the programs, although the structure of what the cascade testing portion of the program looked like was not always very clear. And again, this is another area I'm really interested in. And I think implementation science is really important. And then finally, results are being returned by different types of practitioners. So most are being returned by genetics providers. But interestingly, especially when we think about scaling this up with current shortages in the genetic counseling field, there are programs that are returning results through patient portals and through primary care. And so we were really interested to learn about what all of these different programs were doing. There's a lot of variation, and a lot of these programs hadn't published too much about these contextual factors. And it was also unclear to what extent some of these programs are following some of the recommendations that have come out of the National Academies of Sciences in terms of developing and structuring population genetic screening programs. But still, we were able to learn quite a bit from these sites, and I'll talk a little bit about some additional work that we've done with some of these sites in a moment. So this is what's happening across the US. And now I'd like to talk a little bit about what's happening at UNC, where I am. So at UNC, we have the program for precision medicine in healthcare. This program is led by Jonathan Berg, and the goal of it is really to foster advancements in evidence-based precision medicine approaches. And one of the priorities is doing a clinical pilot of population genetic screening. It's called the Precision Health Genetic Screening Test, and it is free genomic sequencing of 11 genes that are associated with those CDC Tier 1 conditions. And the goal is for this test to be available to any patient in the UNC healthcare system. Initially, the program was envisioned to really be adopted by primary care providers who would then offer the screening to their patients. But unfortunately, and this was true of a lot of other programs we've talked to, this program was getting up and running in 2021 at the height of the Delta variant for COVID. And so there were such competing demands in the primary healthcare space that we ended up switching to a model that is more directed towards UNC health patients. Although I will say in some of these next phases of the pilot, we're hoping to bring primary care back into the fold. And the Precision Public Health team really does sort of start to finish most of the logistics and testing and return of results for the program. There's a dedicated genetic counselor that works to pre-screen and counsel patients who have gone through the program. And so I received some funding to evaluate the implementation of our program, our pilot program, which is ongoing. As I mentioned, it's a clinical offering, and it is underway. We currently have, I believe, about 400 patients who've been enrolled. And the first aim of our work is to better understand the implementation of the program. And we're using sort of a mixed methods approach here by collecting both EHR data as well as some survey data and supplementing that with qualitative interviews, which I'll talk about in a moment. We're really focused on measuring reach and representativeness of the participants in the program. And we're measuring representativeness by comparing the sociodemographic characteristics of the patients that are involved in our program with UNC's catchment area. We plan, as primary care providers become more involved in the pilot, to measure adoption, but we're really focused on better understanding feasibility, acceptability, and appropriateness of the program among the implementers, as well as acceptability among patients. And then we are supplementing with some interviews to better understand barriers and facilitators for implementing the program, as well as understanding how the program has evolved and been adapted over time. The second aim of the project, and I will just go back and say, I'm not going to present data on these implementation outcomes today, and that's in part because we're waiting until we sort of get a little bit farther along in the pilot before we do our final analysis of those data. I will talk a little bit about the qualitative data, though. The second aim really is focused on building off of our qualitative data to identify strategies that could be used to optimize the implementation of the UNC Precision Health Genetic Screening Test. One thing that we've struggled with has been really reaching patients in a expeditious manner. And so we really focused a lot of our questions around how we could improve reach. And then, of course, the experience that patients have once they're in the program. And so I'll first talk a little bit about these strategies. So we are taking some of the qualitative data that we have collected. We've gone ahead and actually, even though we're not done with the pilot, we've interviewed the implementation team as well as the patients so that we can start optimizing the pilot program as we're going. And we're taking those qualitative data and synthesizing them with what we find in the literature to really do a comprehensive needs assessment. And we're using a technique called implementation mapping to build out some strategies that we will use to improve the program. And so first I'll talk a little bit about what we've done in this first step. We haven't completed our implementation mapping efforts, but we've made some progress. And the first thing is our interview guides for the implementation team, as well as the patients, was really grounded in the consolidated framework for implementation research. We were interested in using this framework because it's so comprehensive and it's multi-level. Also, there's been some work in genomics to identify constructs within CFIR that are particularly important to the delivery of genetic services. So we were able to make sure that we included those constructs. And we supplemented characteristics of the individuals with the integrated behavioral model to better understand some of the norms and attitudes that might also be really important for implementation behaviors. And so this guided our qualitative work as well as the way that we analyze our systematic literature review data. And so we did the systematic review first, and our main goal was to identify in the literature what has been found to be barriers and facilitators for implementing population genetic screening. Some of the major gaps that we identified is, and I alluded to this earlier, a lot has been done to understand the needs of patients and the public and some providers in terms of knowledge and attitudes about population genetic screening. But we know a lot less about the clinical level factors and the health system level factors that impact implementation outcomes. So that was another thing that we decided to really focus on in our semi-structured interviews with the implementation team. We identified that there are a couple of strategies that seem to be particularly important in population genetic screening, including provider buy-in in education, as well as providing pre-screen genetic counseling. And then another gap that we identified was there's been very little done around long-term outcomes of population genetic screening. So we tried to, in our work, try to get a sense of what are the important long-term outcomes among our stakeholders, and what should we really be measuring when we, in addition to feasibility, acceptability, appropriateness, reach, and adoption as well. So we used that information to develop our semi-structured interview guides. We interviewed patients who had both positive and negative results. We also talked with our implementation team, which included genetic counselors, clinical geneticists, pathologists, researchers. So we have some educational researchers that work with the program. We talked with them. The coordinators who help with the logistics of the program, as well as the marketing of the program, our lab testing group, our industry partners that we work with, so the group that does the genetic test, and then our IT folks that helped us with the EHR integration. And here's what we're finding. We've completed interviews with patients, but we are still analyzing those data. We have analyzed the implementation team data, which is what I'll share. So unfortunately, like many studies, it seems that I'm involved in, we always identify more barriers than facilitators, but there were a lot of things that are going well. The first being that the folks on the implementation team view this program as being a high priority for the program for precision medicine and healthcare, which they work within. We also, I heard a lot that having dedicated program staff for the program was a real strength, and that helped make the implementation go much more smoothly. The fact that the program has been adaptable and that we've been able to try certain approaches change them and try again was a real strength in terms of trying to optimize the program over time and deal with roadblocks that came our way. And we also heard a lot about a high perceived benefit of population genetics screening, as well as having sufficient resources to carry out the program. A lot of the barriers we heard about were really on the provider and system level. So while the Program for Precision Medicine and Healthcare felt that this was a really high priority, across UNC Health, there was some concern that maybe it was not as high of a priority due to competing demands. Also, potentially because there is a lack of awareness among providers and health administrators about the program and a lack of identified primary care champions. These sort of first 4 bullet points are, I think, priority strategies that we're already starting to work on to try to improve the pilot program. So really figuring out how to improve our engagement with providers and healthcare administrators. We also have been limited by certain health system and policy issues. One of those is we have needed to go, our primary means for reaching out and identifying patients at UNC Health has been through MyChart. And I think we all know that there are a lot of benefits to identifying patients through MyChart, but there also are limitations because not all patients participate and use their MyChart. So that has been a limitation and relates a little bit to that following bullet around low participation among underrepresented groups. We also have run into some issues on a policy level related to the beneficiary inducement law. So this is a federal law that is intended to reduce Medicare and Medicaid fraud and essentially does not allow healthcare systems to provide free services to beneficiaries with the sort of intention of not allowing healthcare systems to drum up business for themselves. So, for example, having a screening test that could then identify a condition that would require additional services. I'll talk more about this law later, but essentially what this law has done is, because this is a clinical offering, not a research offering, and we're attempting to offer it for free, we are unable to offer it for free to Medicaid and Medicare beneficiaries. And obviously that's a huge concern when we're thinking about the representativeness of who's participating in our program. Providers are hearing a lot about concerns from patients related to life insurance discrimination. So that's another potential barrier to getting patients involved. UNC, as any healthcare system, has a lot of systems approval processes for making a new clinical offering available in the electronic health record, and some of those approval processes take time, which can slow things down. The providers involved in the program had some concerns around patient privacy related to their ability to really get engaged in cascade screening of individuals with a positive result. And this is a huge issue in cascade screening, and a reason why I think implementation science and the collaboration with ethicists and legal scholars is really important around cascade screening. And then finally, there are some concerns about costs and sustainment and coverage of this test. So again, it's population genetic screening is not currently covered by most health insurance companies because it is not a guideline recommended screening service by the USPSTF. And so I think that especially with this in mind, during the early adoption phase of population genomic screening, costs are something that remain a concern beyond the pilot program phase. So we were really interested in sort of doing some other work to better understand some of these issues that have arisen. And so I'm going to talk particularly about issues around the beneficiary inducement law and low participation among underrepresented groups. I'll also touch on costs a little bit in relation to that discussion. And so we've done some supplemental surveys to better understand the public's awareness and interest in genetic testing, as well as their likelihood of participating in a population genetic screening program that's described in the survey as it's implemented at UNC. And I always think that this is so interesting and really puts things into perspective. Only about half of the public is aware of what a genetic test is. And I was looking back to some work that I did when I was at NCI with Kate, where we saw something similar in 2017 data, so over 5 years ago, where similarly you see that about half of the public population is aware of genetic testing. So already we're missing a huge portion of the public. Among those who are aware of genetic testing, about half of them are interested in participating in genetic testing. And I think that it's really hard to know what the right, quote unquote, right percent of interest should be. Of course, I think it's really less about who's interested and more about the ability to be informed. So I think really the awareness metric is much more important because if a person is informed and they don't want to participate in population genetic testing, I think that that's potentially okay. And then the final thing is when we look at those who are aware and are interested, they are highly likely to participate in a population genetic screening program like the one that we have at UNC. About 83% of people say that they would be likely to participate. The main reason why people say that they're not likely to participate has to do with things like not wanting to participate in a blood draw, which is the way that UNC's program is currently set up, or time and competing demands. But the thing that we learned from this that I think was most interesting and important to what we were seeing is that when we look at awareness of genetic testing, we see that awareness about genetic testing differs by ethnicity as well as English language competency. And so as we've been collecting data, we have a dashboard that allows us to look at reach and representativeness of program participants. And we have noticed that we have low enrollment around our Latino and Hispanic population. And so this sort of aligns with what we're seeing here and suggests that maybe part of the problem is that we're just not reaching this population who at baseline has potentially lower awareness of genetic testing. Another thing is that, and this gets to the English language competency piece, is that EPIC and MyChart are not available in Spanish at UNC at this time. And so we're really needing to think about an entirely different set of strategies to reach our Spanish-speaking patients. And currently there's work underway to do so. We also are really interested in understanding what some of those other population genetic screening programs have done in terms of reach and representativeness. As I mentioned, uptake of participating in the pilot has been slow, steady, but slow. And so we were thinking, are there other strategies that we could be using to reach patients? What have other programs done, and what are the specific things that they are doing to reach representative populations? And so with 11 different programs across the US, we did qualitative interviews with the implementation leads to better understand what their strategies have been for incorporating providers, patients into their programs and how they've made sure that it's representative of their catchment areas. And what we've found is that there are a number of strategies that these programs are using to increase patient reach. Unfortunately, we don't have the data, nor do many of the programs, to say which of these have been effective. So I think that represents really a gap in the current state of the literature, where there might be strategies that are being used, but we have no idea if they're actually improving implementation outcomes. So I think that's an important area for future work. But the strategies that have been used have included brochures, flyers, and mailings, messaging patients to the EHR, And I thought something that someone said from one site was really interesting about this, which was they have the highest yield of getting people tested by reaching out to patients through the EHR, but it was sort of at the cost of representativeness. And so I think what that person was saying that resonated across interviews is that the strategies that are used to increase reach are not always aligned with the strategies that are going to increase representativeness. And we really need to be thinking about those two things differently. And we really need to have strategies specifically focused on representativeness, which I'll get to in a minute. Many of the programs use community events. And I'll talk a little bit about this when we talk about representativeness. Sometimes these community events were broadly to increase reach. Other times they were specifically centered at community events that would allow to increase representativeness of their participation. We found that social media was an important mechanism for increasing awareness of programs. Just a couple of sites use direct recruitment from within specific clinics. So they tried to identify where are people being seen who might be most interested in population genetic screening. So mammography clinics and cardiovascular clinics were often targeted. And then there were some one-offs that where people were specifically doing online consents to increase reach, specifically using saliva kits to increase reach. And one group even used vending machines to distribute their collection kit. They didn't find it was effective, but I thought that was interesting. And then there was also some strategies that were discussed that were specific to improving representativeness, including community pop-up events where people went to where people are and had the testing capability there so that a patient could learn about the genetic testing, get tested that day, and participate. A number of places also partnered with rural clinics for outreach. I thought this was actually a little disappointing, and perhaps there are programs that are doing this that just didn't mention it, but only 3 programs mentioned translation of their patient materials to other languages. And in other areas of genomic services use, this has been something that's come up in my work, that there is very little resource material for patients who speak languages other than English. But this is being used by some sites. Mailed sample kits to directly reach participants to improve representativeness, so targeted mailing, and then community advisory boards as a way to solicit ideas for increasing representativeness. I also mentioned the beneficiary inducement statute earlier. So we were interested, not all of the programs that we talked with were clinical. So if you're a research program, the beneficiary inducement clause is not applicable. But we were interested to hear sort of what these groups that were clinical were doing in terms of covering the test, because as we saw, most places were covering the cost of the test. And what we saw was that 2 of the sites received waivers through their accountable care organizations, through bundled payments, and then others provided testing at cost. And what's interesting is the cost of the population genetic screening test varied across programs. And so the cost at one program was $50, $99 at another, $250 at another, and over $500 at a 4th site. And I'll come back to these costs a bit later. And then one of the programs was state funded, which also allowed them to sort of alleviate the concerns around the healthcare system providing a free service. And
Megan,
so
just a quick time check. We're about 5 minutes to the top of the hour.
Oh, perfect.
And you've got
Thanks.
some questions in the chat.
Oh, okay, great. I will, I'm just looking, there's some good questions in there. So I'll quickly breeze through this. So when we were looking at the fact that, 4 programs had self-pay, we were interested to know what are people's willingness to pay for population genetic screening? And if we offered our test at UNC, which is $250, would people buy it? or would we still be excluding patients, the majority of Medicare and Medicaid patients? And what we see when we ask people about their willingness to pay for those different price points that programs are charging, 74% of people will not pay $250 or more. So that's the majority of people. So we feel like really, offering the test at cost is not going to really solve our problem of making sure that we've got representative Medicare and Medicaid beneficiaries in there. And so we've done some additional work to we've partnered with some ethicists and lawyers, legal scholars to try to think about other ways. There are exemptions to this statute. And the one that we are particularly interested in is for programs that are designed to promote quality care and better outcomes, it's unlikely to lead to overutilization or inappropriate utilization. We thought maybe that would apply, but unfortunately, that's just a risk the healthcare system would have to take, that this exemption would hold if we were to do that. So that was unfortunately not an option. And then, of course, there are political processes that you can undergo, which take time. One of our hopes is that eventually this will be a recommended screening, and then it'll be covered, and recommended beneficiary inducement recommended screenings through USPSTF are not held, would not be exposed to the beneficiary inducement statute, so it would be excluded or exempt. And then finally, we looked at strategies for increasing provider adoption, primarily around champions, training, and EHR and resources. We're now working on designing our implementation strategies. We need to get the patient data for patient strategies. We're using the Eric Waltz matching tool to sort of select a group of strategies. We will prioritize them with our stakeholders, and then we will use implementation mapping to really build out and develop those, and develop an implementation plan so that we can, in future work, see if they improve our implementation outcomes. And then finally, we're looking at health outcomes and really focusing on trying to build out infrastructure in a way that we can continue to look at the outcomes of people who participated in the program over time. And so I'm going to skip this slide with future directions and go ahead and do a big thank you, and I'll leave up my acknowledgements for all of my collaborators who've helped with this.
Thank you, Megan. Talk about scope and multi-level approaches to everything from policy all the way down to the nitty-gritty of individuals. So I have questions, but I'm not going to actually steal the right to ask you them. I really want to talk about tailoring and sustainability, but we have so many wonderful questions in the chat, and I know we only have 2 minutes, so I might sort of combine some of them. I think that there is, this tension between acceptability, measure of trust, all the complexities that come to bear. And so I think maybe, sort of how are you thinking about both targeting and measuring acceptability, particularly with regard to trust, health literacy, provider self-efficacy. There's a lot of different components that are hard to measure and rely upon response, of course. So if they don't respond, sort of making sure that you can assess those. So
yeah, that's a great question. And so for measuring acceptability, we are using Brian Weiner's measure of acceptability. But we're also including a lot of other questions in our survey that goes out to participants after they've received their results. Another great thing about a lot of this work is it's really multidisciplinary. So we have bioethicists and social psychologists and people from all different disciplines who have put questions into the survey around trust, knowledge. There's a genomics knowledge scale, as well as some sort of perceived views of their health literacy that are included in this survey. So that I know that we're not going to be able to look at everything with 100% power. All of the all of the different factors, but we're hoping we can at least do some analyses to develop some hypotheses around what the really important factors are around acceptability, and some of these other really key determinants of implementation outcomes.
I know it's 12 o'clock, but I want to just one last question, sort of building off of Sonia's. You know, there's two sort of tricky things here, or many tricky things, but one is the sort of implementation and getting it into the systems. One is also getting it sort of covered as a screening. Is there sort of if you could identify what evidence, whatever that may mean, that sort of could push this into that space, what might it be, and how likely do you think you can get there?
Yeah, so one thing I'm increasingly interested in, and that we're starting to pursue, I do think that I think there's a bit of a chicken and the egg issue, where I think for developing clinical guidelines, there needs to be clinical data that suggests that it improves health outcomes, but you need to have representative pilots that are taking place that are providing those data, and so it's a bit tricky. And so I think that's why a lot of these programs are research programs. They're still generating the very same data that will make this guideline incorporated. The other piece is I've been thinking a lot about how important, across a lot of the different projects I'm working on, buy-in and identifying and engaging champions are. And so we're just starting some work to try to understand what can we learn from other disciplines outside of health and implementation science about best practices around establishing buy-in with providers and healthcare administrators, and engaging champions. So I'm sort of excited to see where that goes as well, because I think there's the data piece, and then there's also just figuring out the right way to approach some of our partners and getting them excited about the pilot.
Well, I could continue talking for much longer than we have, but to be respectful of everyone's time, I just want to say a huge thank you. I'm really excited to see where all this goes, and we'll be watching you, and happy to have you back when you have the data coming out. So thank you so much, Megan, for joining us, and for all of you as well. Be well, be safe.
Thank you so much.
Thanks for having me.